So I would like to introduce Daphne. She's a clinical nurse specialist at Northwestern University Feinberg School of Medicine in Chicago for over 17 years and has worked with Dr. Mark Molich, who's an endocrinologist. Daphne also serves as a project manager and for clinical trials for pharmaceutical studies in endocrinology, nephrology, and gastroenterology. Daphne specializes in acromegaly and many multiple other endocrinology disorders. Daphne Adelman has presented nationally and internationally on acromegaly, Cushing's, and medical devices, and also part of an international nurses union. Please welcome Daphne Adelman.
Okay, so I love Canada. I was actually surprised when Dr. Izat said there were some health health concerns too that you guys have, because there is nothing like the U.S. and our FDA and our access to drugs. As Jill knows, I've been having so many issues getting drugs to our patients. So I always thought Canada was awesome because you guys have. My cousin had 18 months of maternity leave. I mean, who does that? And you guys get paid for most of it. It's crazy. I'm so, so you guys are, and actually, I'm not going to bring politics in, but many of us were going to come here if such and such was voted. So, anyways, just want you to know that I've been doing acromegaly for over 18 years, and I've met such wonderful people. And I mean, Lori has it down packed. She's beat me 38 years. I've been doing acromegaly 18 years, but I was in the hospitals prior to that before doing research. And I'm kind of a combination between Lori and Jack. I mainly do research clinical trials. I've probably done over 80 clinical trials from mostly pituitary, but then I'm also doing nephrology and also gastroenterology now too as well. But as far as acromegaly, Lori is like the queen of acromegaly. All her pamphlets we've tried to borrow and use and utilize for other things, but it's a different system, so sometimes it's harder to implement some of it because we have one bad thing that we have is a lot of insurance issues. So that's the problem, is for us to get the drugs to our patients. But we do our best that we can, and in fact, one patient was saying, what happens in the U.S. when you don't have that option to get medication? Hopefully we have patients that actually will donate, but technically we're not supposed to do that. But you know what? If I have a patient that's desperate and needs drug, I will get it for them. I mean, I don't care if I'm doing something wrong. I'm probably hopefully there's no bugs here, secret spies. But Jill and I have done, made efforts to get patients their drugs, even if we have to pay out of pocket for the FedEx. And then also we get them into clinical trials because, to be honest, clinical trials are so important. And as Deanna alluded to, once you commit to a trial, we really need you to stay in the study. So if you're not going to commit for the whole time, that's okay. Maybe there'll be another time. There's going to be a lot of trials out there. But most of them are only 6 months. Some of them can be years because once the drug is started, and a lot of these companies do commit to the end, getting it out on the market, which is the end goal, because we want options for you. That's the bottom line. And I'll show you from my slides that there weren't a lot of options when we first started. When Lori and I were first there weren't. There were only one or two. So it's really getting it's going to be an exciting time, as Jack alluded to. There's so many drugs coming out there. We're so excited. I mean, I have 4 trials on acromegaly alone starting, and I just found out from my colleagues that apparently we weren't invited to this other one, but there's another one. There's an investigator meeting in October next month for another drug for acromegaly. So these are my objectives. It's kind of an intermash. It's repetitive, but I think it's important to repeat things, because especially when you're newly diagnosed, it's information overload. You're going to be, with all the tubes that you have to get drawn, all the tests, all the procedures, it's just a lot for somebody to handle. I mean, anything, with any chronic condition, but especially with acromegaly, there's even more stuff. So I think repetition is always good. We'll go over some of the diagnosis. And then Stages of loss is what I really believe in as far as how I'm going to treat my patients. And then we'll talk about treatment management and the endocrine nurse's role. We really are the ones that are going to be there for you for everything. I mean, look at Lori has dedicated her life. I mean, I have as well. We're really there for you, and we work 70 plus hours a week, to be honest. And I mean, we love our jobs, but we have to have a life too. And she's starting to realize that as we get older, we're realizing that we've missed out on a lot of our lives as well. So we want to try to, if we can learn to delegate, that's a problem. We're so OCD that we're afraid to give everyone else the chance, But anyway, so acromegaly, in the beginning, when I first started over 18 years ago, there wasn't a lot. I mean, and then now look at where we're at. We had a meeting in New Orleans. There were over 200 people, and thanks to our advocacy groups, there's at least over 3,000, 4,000 people that now can connect. And I do believe the one-on-one is always the best, but still, at least that online option is available too for those people in other parts of the world that we can't reach. So unfortunately, as we've said in all the presentations so far, it's a slow, insidious path to diagnosis. I mean, unfortunately, it's still about 7 to 10 years, unless you inadvertently, like at Mass General, theirs is like 3 to 5 years because they automatically do MRIs for patients a lot, because they have a lot of patients, and maybe their MRIs are cheaper there. But theirs is 3 to 5 years, but for most institutions and most countries, it's still 7 to 10 years before you get an official diagnosis. And one of the things so I know there's a few of you that are newly diagnosed, and I just wanted to bring up so the problem is there is a disconnect between the healthcare providers and the patients, because we see things a little bit differently. We're looking at numbers, we're looking at your features, we're looking at all these symptoms, your levels, the biochemical markers, your IGF-1s, your GH, and then we're looking at the adenoma, which eventually causes all these issues, because the growth hormone causes all your organs to enlarge and causes the headaches, everything. But then I think what we're turning towards, and this is where this is actually moving after our Pituitary Society meeting, we're trying to get the healthcare providers to realize that we need to start listening to the patients. We can look at the numbers, but that's not, someone at a certain level of IGF-1. So we get these assays back from the lab. And one of the things is you want to try to use the same lab. I don't know if in Canada if you guys have one particular lab that does all your IGF-1 levels. So that's good. At least you have consistency. See, with us, because of insurance, we have like 10 or 15 different labs, and then we have to treat a patient and then also, adjust their doses. And one lab, I've done testing. I did a research IGF-1, and then I did 2 labs from one with Quest and one with another lab. And they were 50 units apart. And I'm like, how can you determine if the person's in normal range if they're one's 50 higher than the other and the other one's 50 lower? It's crazy. So that's what we see, or that's what the physicians see. I think the nurses are more, we see the patient more. But then, and you can add to this list, what do the patients see? I mean, from just all my years of being with my patients, I mean, they see that they have a lot of symptoms. They're seeing that they don't have any diagnosis yet after going to different doctors, whether it's the GP, the PCP, or even the local endocrinologist. Many doctors visits with no definitive answers. They might be mixed diagnosed many times over the past 10 years. And what they see is confusion, frustration, and anger. By the time I get to my patients, Lori's not wrong. Try to be nice but I don't blame you for not being nice, because you're just frustrated. You're angry. I mean, if I was misdiagnosed for 10 years, I would be pissed, So that's the same thing with the initial diagnosis. Once you actually do get the diagnosis, this is what we see. We see a rare condition. We see an adenoma, usually caused by, benign, non-cancerous of the pituitary. We also see a lot of growth hormone secretion. And then basically we see that you might need surgery. And just to show you, so acromegaly and Cushing's are probably the least of all the pituitary adenomas, 5 to 10%. So again, what do you see? And I've had patients say this, oh my God, I have a brain tumor. Am I going to die? Is this cancerous? Do I need brain surgery? And then the bottom line is they ask, will I be able to live a normal life? And that's the goal. That's the end game here. Is I want to promote the best quality life for everyone. So this is my own interpretation, but I really believe that whenever you're diagnosed with a chronic condition, you do have to go through these 5 stages of grief. It's like basically death, because I consider a chronic condition a loss. It's almost like a loss of your normal function. So you're going to go through, you're going to go through the denial, definitely the anger, especially after being shifted, to all these different providers and not knowing a diagnosis. Then you're going to bargain because you're like, no, I don't have acromegaly. What is it? I must have something else. And then finally, you get depressed, and that depression can last a long, long time. So that's why I'm glad the psychologist was here yesterday. He was awesome, by the way. And then finally, acceptance, we try to teach at these first 3 times. We try to educate patients at these first 3. They are not going to learn anything at that point. It's really going to be once you hit acceptance, that's when we can really start to really educate you and try to, give you your options and what you're going to go through, and that's when you can learn the most. And even then, it's going to be many times over. So I really believe that this Kubler-Ross model can guide our patients to learn to live with their conditions. And it's an ongoing thing, though, constant, because throughout your lifespan, just like every stage that we go through as we age, there's going to be a constant battle. So patients go through constant battle with coping with their diagnosis and accepting their condition. I truly believe that. So once you finally, accepted your diagnosis, then maybe you had surgery, and then you realize, oh my God, I need more medication because my levels aren't controlled. So again, you need to go through that whole grief process that, oh God, now I'm going to be on these lifelong meds. It's like a constant battle. And I think as providers, we need to really think about that. And, when we're trying to, develop our care plans and just to develop our relationship with the patient, we need to be more empathetic. We need to know that that's how, what patients are going through. And I think it is changing. Honestly, like Dr. Izat and his wife, you guys are so lucky to have that in Canada. We have providers, I love my boss, as Jill knows. He's great, but he's old school. He doesn't think outside the box. So he doesn't have that empathy that Dr. Izat had. So be thankful. So, and then again, there's also, once you've accepted that you need medication, then there's an ongoing battle of what kind of medication you'll need. So that's another battle itself. And unfortunately, right now, there are only the 2 injectables, okay? And then with that, there's always a lot of teaching, because then you have side effects, and then and they're unfortunately not a permanent cure. And they're very costly in the U.S. One injection a month is like $5,000 to $7,000 for us. And if it's pasrietide, it's like 12. Sorry, Novartis. I feel bad, the Novartis people here. Anyway, it's a constant battle of just trying to get, to really understand what the patient's needs are and how to educate them. So the bottom line is, I really do believe we have to put ourselves in our patient's shoes, and I feel like when I'm talking to a patient, it's like they're a part of my family. Like, how would you want your mother or your kids to be treated? That's how we have to start looking at things. It's important because at the end of the day, we're all human. We all want to have the best for everybody, for ourselves and for our families, and And I know Lori does that with her patients, and there's a handful of us that do that. Okay, maybe we're still a little bit old school, but we really believe that, why did we go into this career? It's really about helping our patients, and that's very important to us. So empathy and sympathy. Because your endocrine nurse is going to be the one that will get you through this journey. There's so many things. Look at all that stuff that Lori brought with us, which hopefully she'll pass around later. We're teaching you all the injections, and all these injectables have to be, for the most part, refrigerated. So there's a lot of learning with everything, and it takes time. We're not going to just throw you to the wolves and just, it does feel like that sometimes, I'm sure. You feel like, there's so much information overload. So this is a process. It'll take time, but we will get you there. And we do have a lot of the tools. I mean, the pharmaceuticals have actually provided us with nice tools as well to help us and help you educate. So we'll go over like how to prepare the meds, the actual injections, where to inject, how to store it, also all the massive side effects of the injections, and then basically we're your go-to point of contact for both clinical practice and then like Jack for studies. We're the ones that you're going to go to for these kind of things. So this is just a summary of why. I guess I'm just touting the endocrine nurse. I really hope you value your nurses, and I hope. So in the U.S., we don't always have an endocrine nurse. Like a lot of us we have very fragmented care. I mean, some offices they have an MA, medical assistant. They don't even have a nurse. So if you do have a nurse, give her a hug and thank her for all she does for you. Because we're the ones that are the first ones to do early detection. We do a lot of the patient education. Definitely medication compliance. We really, if you're not going to take your medicines, they're not going to help. I always have patients like with high blood pressure. They're like, oh, my blood pressure's fine now, 120/80. I'm like, oh, can I stop taking my meds now? I'm like, no, don't you get it? You're taking your blood pressure pills because that's why it's, your blood pressure is 120/80. So there's a lot of teaching involved. And then support. I think it's with the nurses, we're the ones that you really feel more comfortable with, especially with body image issues. And as much as Mark says, so I agree totally with Mark. The men, all of my male patients have gotten more chiseled features. They're they feel more handsome for the most part. But unfortunately, the women, we're getting, you're getting those features. They're not, they're not, who wants to be more chiseled and, get all these, extra brows and stuff. It's different. So we have to do, and I know in Jill's group, they have a women's group, but there's different issues that we all that we all have. So it's nice to be able to have, someone one-on-one that has acromegaly that you can talk to about it. Because I don't think anyone can understand unless you actually have the condition. But at least as nurses, we can, direct you to where you need to go for that to get the support you need, whether it could be a psychologist as well, or a referral to even a social worker or whatever. And then lastly, this is more for me on financial support, just because we have so many issues with insurance. So a lot of times, just to get the drugs to the patient is a big process, and it's a nightmare to tell you. It's not something I enjoy doing, but I will do it for a patient just because, everyone deserves access to their medications. I think it's a given right, And then lastly, this is the big thing. You're so lucky to have this support group. And I think a lot of the world is turning to support groups for advocacy support groups. And I think the advocacy support groups are what's going to help transition and bring a lot of these drugs to the market. We have to be a bigger voice. Like Dr. Asa was saying, we have to, numbers mean a lot. And that's why a lot of the cancer and the cardiology groups get things done. We have to really, band together to get things going. And there are a lot of support groups. That's how I met Deanna. I mean, WAPO, has been trying to bring advocacy groups across the world. And we meet once a year. And just bridging patients from all over the world, because we all have different healthcare systems, but if we can just work together to try to, overcome a lot of things, and actually, it's great brainstorming, because what's already been done in one country can be applied in another country. We just, we don't really need to reinvent the wheel. We just have to, get some ideas going, and I think we can really move forward in a lot. And as Jill can attest to, that, the FDA meeting is going to be pivotal. So my last thought is basically, I think it's important to work together between the patients, the healthcare providers, the advocacy groups, and then also pharma. I never realized how important pharma was as far as, and because of this meeting, because of the pharma support, that's why we have these kind of meetings. We really need pharma as well, not only for these important medications,